This is the extracranial view of the occipital bone. In the midline, we can appreciate the inion, also known as the external occipital protuberance. The inion can be used to anticipate the position of the torcula, approximately 1 cm superior to it in the endocranial surface. At each side of the inion, we can appreciate the superior nuchal line, which is formed by the insertion of the nuchal muscles. This line can be used as a guide to the position of the transverse sinus. The inferior nuchal line, here in brown, is the insertion of the suboccipital muscles. At the midline, the external occipital crest corresponds to the falx cerebelli and the occipital sinus intracranially. Here we are looking at the endocranial surface of the occipital bone. Notice the transverse sinuses at each side of the torcula, and you should see, in your mind's eye, the tentorium at that level. We can also enjoy a representative view of the superior sagittal sinus, which typically is to the right of the midline and towards the right transverse sinus. Take a moment to understand how the jugular tubercle is in the way to the lateral trajectory to the clivus. The posterior fossa is bounded by the occipital bone, the petrous part of the temporal bone, and the dorsum sellae of the sphenoid bone. This anatomy is very rich in detail, so I invite you to study it with passion and appreciate its subtleties as an advantage to make you a faster and safer surgeon when navigating through the far lateral, the extreme lateral, the retrosigmoid, or the posterior transpetrosal approaches. The jugular foramen has its roof in the temporal bone. The intrajugular process is a spur of bone that connects the jugular tubercle through a thick band of connective tissue and divides this space into the pars venosa, posteriorly, and the pars nervosa, anteriorly. At the pars nervosa, the sigmoid sinus becomes the jugular bulb and receives the inferior petrosal vein, which drains the anterolateral aspect of the medulla. The pars nervosa is used by the vagus and the accessory nerves. The vagus nerve gives Arnold's nerve at the foramen level. The glossopharyngeal nerve exits through the jugular foramen anterior to the pars nervosa in its own small tunnel of connective tissue. At the foramina segment, the glossopharyngeal nerve gives the tympanic or Jacobson's nerve, which will later meet the tympanic plexus on its way to the parotid gland. Anterior to the glossopharyngeal nerve is the inferior petrosal sinus, at the end of its trail through the petroclival synchondrosis. We are looking at the lateral wall of the posterior fossa through the foramen magnum. The internal acoustic meatus, the jugular foramen, and hypoglossal canal align, forming the neurovascular curtain, which divides the posterior fossa into the ventromedial compartment anteriorly and the dorsolateral compartment posteriorly. This is a good picture to use your imagination and try to see in your mind's eye how the endoscopic endonasal, the orbitozygomatic, the coase, the transmastoid, the retrosigmoid, and the far lateral approaches relate to these foramina and their neurovascular bundles. This is a surgical simulation of a left far lateral approach in a park bench position. In this step, I have turned a musculocutaneous flap using a hockey stick incision and reflected the nuchal muscles inferior and lateral. A critical step of the muscular dissection is to expose the suboccipital triangle. A good way to start is by exposing the inferior nuchal line and identifying the rectus capitis posterior major medially, the superior oblique muscle, and the inferior oblique. Notice that these attach to the lateral mass of C1 and the spinous processes of C2. Within the triangle lies the muscular branch of V3 segment of the vertebral artery and its venous plexus. The V3 segment will be just under the plexus at its sulcus arteriosus. Notice the occipital artery position, lateral to the superior oblique muscle and medial to the posterior belly of the digastric muscle. After transposing the muscles of the suboccipital triangle, the V3 segment of the vertebral artery becomes very clear. Notice the C1 nerve exiting the dura so close to the V3 segment and joining it at the sulcus arteriosus. Medially, the rectus capitis posterior minor attaches to the arch of C1 and marks the midline by the external occipital crest. Now focus on the structures lateral to the lateral mass of C1. We find the internal jugular vein traveling so close to it. If you pay attention to the internal jugular vein, you'll see a small muscle that has been transected at the occipital bone just medial to the point where the vein exits the skull. That was the rectus capitis lateralis, which originates at the lateral mass of C1 and attaches to the jugular process at the posterior edge of the jugular tubercle. That is a great landmark for expanded approaches to the jugular bulb. Here is the craniotomy for the left far lateral approach. In cases where the lesion extends below the foramen magnum, or if the vertebral artery needs to be transposed, let's say if you need to do an extensive condylectomy, for example, the lateral lamina of C1 may be removed with a roofing of the vertebral artery at the foramen transversarium of C1. The size of the suboccipital bone flap may be customized to the surgical target, but for anatomical purposes, I have exposed the transverse, the sigmoid, and the marginal sinus. Notice that little blue channel below the sigmoid sinus at the condyle. That is the posterior condylar emissary vein, which connects the suboccipital sinus with the jugular bulb. This is the intradural exposure through a left far lateral approach, an extremely beautiful landscape of surgical opportunity. To get to this view, I have opened the dura laterally to allow maximal view without tension on the petrous ridge. Then I have drilled the occipital condyle until the hypoglossal canal, and finally I have drilled the jugular tubercle above the hypoglossal canal with great care to preserve the accessory nerve, which you can see kissing the dura at that point. Starting from caudal, at the top of your screen, you can see the spinal cord with the dorsal rootlets of C2 and the spinal rootlets of the accessory nerve immediately in front of them. The little serpentine artery is the posterior spinal artery, which, if you trace to its origin, you will see it sometimes exits dangerously close to the dural ring of the vertebral artery. Lateral to the accessory nerve at that level is the dentate ligament. Now see how the vertebral artery transitions from its V3 to V4 segments when it enters the dura, just lateral to the accessory nerve and anterior to the hypoglossal nerve. If you find the hypoglossal nerve at the canal and trace it to its cisternal segment, you'll see that sometimes it has two different rootlets, with the P pica running between them. Let's check the jugular foramen now. You can see the accessory nerve inferiorly in contact with the dura of the tubercle and receiving medullary rootlets just as it enters the jugular foramen. It is and looks different from the vagus nerve, which is a compact bundle of rootlets. Notice the connective sleeve around the glossopharyngeal nerve and stop and think how critical this is while dissecting a lesion in this region. In practice, the glossopharyngeal nerve should be treated as an independent nerve when it comes to dissection and manipulation. Observe the triangle in yellow, which illustrates the vagoaccessory triangle. This triangle, described by Dr. Lawton, may be further divided into supra- and infrahypoglossal, giving corridors to the P pica, vertebrobasilar junction, and lesions in the ventromedial compartment. The retrosigmoid approach provides a trajectory parallel to the petrous part of the temporal bone. The retrosigmoid approach is a natural corridor to the cerebellopontine angle, but it can be expanded to reach lesions involving the petrous apex, the clivus, and the internal acoustic meatus. Lesions involving the lower aspect of the jugular foramen and the anterior medullary cistern may be better exposed through a far lateral or endoscopic endonasal approach. Planning the retrosigmoid craniotomy involves being able to anticipate the location of the transverse sigmoid sinus. The asterion, where the lambdoid, occipitomastoid, and parietomastoid sutures meet, may be a good landmark to place that burr hole, posterior and inferior to the transverse sigmoid junction. Drilling over the mastoid ridge will allow exposure to the sigmoid sinus as depicted in red. Doing so will allow transposition of the sigmoid sinus anteriorly, therefore increasing the surgical corridor with increase of surgical freedom and lighting. Here are some structures that are relevant to the retrosigmoid approach. Of note, the subarcuate artery, a branch of the AICA, enters the subarcuate foramen to feed the osseous structures of the middle ear, and it is considered safe to sacrifice if doing so improves final access to the internal acoustic meatus or the petrous apex. It is also important to realize that the posterior semicircular canal sits just above the vestibular aqueduct. A closer look to this area should help you create, in your mind's eye, the geography of the petrous part of the temporal bone while advancing the intradural dissection during a case. See the relationship between the subarcuate foramen and the roof of the internal acoustic meatus, the proximity of the vestibular aqueduct to the sigmoid sinus, and how a corridor above the meatus will lead you to the petrous apex and therefore Torellus canal, whereas the corridor between the meatus and the jugular foramen should lead you to the clivus. This is a surgical simulation of a right retrosigmoid approach. I have elevated the musculocutaneous flap and exposed the posterior aspect of the mastoid process. If you're able to expose the occipitomastoid suture during the case, you should be prepared to anticipate that the sigmoid sinus will sit approximately 1 centimeter anterior to the suture, a bit anterior to the mastoid ridge. Also, limit the inferior dissection and be cautious to follow the posterior belly of the digastric muscle inferiorly as it intersects with the facial nerve at the stylomastoid foramen. The retrosigmoid craniotomy is limited superiorly by the transverse sinus and anteriorly by the sigmoid sinus, both exposed here. The dura may be incised so that it can be folded anteriorly to flatten the sigmoid sinus and increase the surgical corridor. There are all sorts of personal opinions regarding the risk of sigmoid sinus thrombosis as you fold the dura anteriorly for the expanded retrosigmoid approach. However, there's no established consensus. There are few things in life as complexly beautiful as the cisternal anatomy of the retrosigmoid approach. First, notice that purple suture flattening the sigmoid sinus to the petrous surface. The first step to allow this exposure is to open the cerebellomedullary cistern to drain CSF and to relax the cerebellum. The first structure on the way to the brainstem is the superior petrosal vein or Dandy vein, which arises from the upper aspect of the cerebellopontine cistern and connects to the superior petrosal sinus at the tentorial surface. Dandy's vein has many tributaries, but notice and try to preserve the most important one, the cerebellopontine fissure vein, which drains most of the lateral brainstem. The vestibulocochlear and facial nerves are the most lateral within the cerebellopontine cistern and enter the internal acoustic meatus together with the labyrinthine artery. The interrupted line illustrates the transmeatal expansion of the retrosigmoid approach. Above the 7 and 8 complex is the trigeminal nerve. Notice that the nerve above the main trunk must belong to the trigeminal nerve as well, because the next superior nerve, the trochlear, runs within the ambient cistern and the cerebellomesencephalic fissure. Below the 7 and 8 complex and above the glossopharyngeal nerve is the pons, with access to the cisternal segment of the abducens nerve, and at reach for the prepontine cistern. Just superior to the glossopharyngeal nerve is a thick membrane that marks the transition between the cerebellopontine and cerebellomedullary cistern. Although possible, access to the cerebellomedullary cistern should be best reached through the far lateral approach. The temporal bone is the most stunning bone in nature because it plays a critical role in shaping the intracranial space. It transduces airways into perceived sound and it generates sense of balance. Also, it protects the transcranial segments of both the internal carotid artery and the facial nerve. Mastering the transpetrosal approaches is all about mastering the temporal bone anatomy. This is a right temporal bone seen from in front. Notice how the greatest superficial petrosal nerve runs on top of the internal carotid artery in its petrous segment, defining the lateral limit of the coarser rhomboid. Lateral to the carotid is the eustachian tube marching towards the middle ear posteriorly. This is a lateral view of the same temporal bone. The posterior projection of the zygomatic arc is called the temporal line. This line can be used to infer the level of the tentorium intracranially. The spine of Henle aligns with the lateral semicircular canal, which lies beyond that point deep in the surgical exposure. The lateral semicircular canal is important because it is the first petrous structure exposed through the transmastoid approaches and also is in contact with the facial nerve. The posterior transpetrosal approaches must be understood as a progression. The initial mastoidectomy leads to the retrolabyrinthine approach, which gives access to the posterior fossa through the Trautmann's triangle. The risks of the retrolabyrinthine are injury to the sigmoid sinus, inadvertent injury to the lateral semicircular canal with risks of hearing loss. The translabyrinthine exposes the entirety of the internal acoustic canal by removing the claustrum and the semicircular canals. That carries deafness of that ear. The transcochlear expansion involves exposure and drilling of the middle ear, including the cochlea and exposure of the eustachian tube. This allows access to the anteromedial compartment of the posterior fossa, including the vertebrobasilar junction, the basilar artery, the AICA, and the pons, but also carries an additional risk of injury to the petrous segment of the carotid. For the posterior transpetrosal approaches, the patient is positioned lateral so that the mastoid becomes parallel to the floor, and a C-shaped incision from above the pinna to a finger breadth below the mastoid tip is performed. That gives full access to the mastoid process as well as the supratentorial space in cases where a combined approach is needed. The posterior auricular and sternocleidomastoid muscles are reflected inferior and anteriorly until the external acoustic meatus is exposed. Here we have completed a mastoidectomy and exposed the semicircular canals and facial nerve. Notice the limits of our surgical field. Superiorly, at your left-hand side is the dura of the temporal and occipital lobes, which is exposed after removing the bone at the temporal line. Inferiorly is the tip of the mastoid process and the digastric muscle. Posteriorly is the sigmoid sinus and anterior is the external acoustic canal. The key to a good mastoidectomy is to remove the mastoid cells towards the lateral semicircular canal using the spine of Henle as reference. It is key to stop drilling as soon as the semicircular canals become apparent, because opening a semicircular canal may cause deafness of that ear. Note the proximity of the facial nerve to the lateral semicircular canal here. The dura behind the posterior semicircular canal forms the Trautmann's triangle, which is the working window provided by the presigmoid retrolabyrinthine approach. Please take a moment to enjoy the views as the jugular bulb arises at the jugular foramen. The chorda tympani takes off from the mastoid segment of the facial nerve towards the middle ear, and the incus shows its head at the antrum. Now we are looking at the posterior wall of the internal acoustic meatus. This corresponds to the view through the translabyrinthine approach. To get here, I have removed the semicircular canals as well as the claustrum. Note the subarachnoid artery just at the roof of the canal. Now take a moment to understand the slope of the internal acoustic canal and see, in your mind's eye, the course of the vestibular nerves and how the same anatomy would look like from a retrosigmoid approach. After completing the transcochlear approach, the posterior bend of the internal carotid artery is exposed as well as the eustachian tube, just lateral to it. To get here, I removed the cochlea, the malleus, the incus, and stapes, and the tympanic membrane. It's quite a tricky drilling exercise, but the final exposure is astonishing. Note that both hearing and balance in this side are gone. So the vestibular nerves are now transposed inferiorly so that we can enjoy the view of all segments of the facial nerve, including the geniculate ganglion with the GSPN and the chorda tympani. Now see the intracranial exposure, anterior to the facial nerve and anterior to the trigeminal nerve. Take a moment to understand the bone just in front of you. That's right, the petrous apex. That's the posterior aspect of the Kawase or anterior petrosectomy. Now is the time to visualize in your mind's eye the Kawase exposure and to build a complete transpetrosal surgical mastery. The pterional approach provides a lateral trajectory to the anterior, middle, and pituitary fossa. The craniotomy for a pterional approach is centered at the pterion, which is the confluence of the squamosal, coronal, parieto-sphenoid, and frontosphenoid sutures. The size of it should be tailored to the features of the target, which includes the size, the depth, and the anticipation of key rescue maneuvers like proximal or distal arterial control. The thought behind the size should be driven by the common rule in skull base. The bone should never limit your surgical exposure or surgical freedom. The keyhole for the pterional approach, also known as the Dandy keyhole, is typically located just under the superior temporal line, as you can see in the left upper picture. It's key to direct your burr superiorly to only access the anterior fossa. Now, in some cases, a deep target like a high-riding basilar tip aneurysm may require an orbitozygomatic extension of the pterional approach. The one-piece orbitozygomatic approach requires a McCarthy keyhole, which can be found roughly a finger breadth posterior to the frontozygomatic suture at the level of the frontosphenoid suture. Note that this keyhole gets you to the roof of the orbit, exposing the periorbita and the dura at the same time. Take a moment to visualize in your mind's eye how the roof of the orbit would project into the skull. The pterional approach is centered around the sphenoid ridge intracranially. See how if the sphenoid ridge is followed, you'll reach the superior orbital fissure first, and you'll arrive to the anterior clinoid process last. Take a moment to enjoy this picture and remember that anatomical complexity is our best navigation tool. I challenge you to find the foramen of Vesalius, the lingula, and the tubercle of Princeton if you're hungry for more. At the core of the skull is the pituitary fossa. In this oblique view of the sphenoid bone, you'll find the key landmarks for surgical navigation. First, understand the relation between the greater and lesser wings of the sphenoid bone and how they form the superior orbital fissure. Now look at the planum and see the depression between the limbus and the tuberculum. That's the chiasmatic sulcus. Pause there and realize the importance of the relative position of the chiasm to its sulcus. If they touch each other, you have a patient with a prefixed chiasm, which would make the pterional or subfrontal access to the pituitary gland challenging. However, the same circumstance may play in advantage through the endoscopic endonasal trajectory. I invite you to do the same exact exercise continuously when studying the normal anatomy. See the surgical meaning of it. Here you have another chance to practice and exercise this concept with the intercarotid distance. just after it runs out through the carotid groove. And imagine how that would impact the endoscopic and the nasal perspective. Here I am trying to summarize the critical points of raising a pterional flap safely. When the temporalis muscle must be transposed posteriorly, the facial nerve needs its own flap. A subfascial or interfascial facial nerve flap may be used. The key points common to both flaps is the fascial incision should never start anterior to the posterior 1/3 of the zygomatic arch, and the incision should be carried supraosteal of the superior temporal line. Take a moment to see the facial nerve in detail. Remember that the superficial temporal artery runs a layer above the nerve, above the galea. Also realize that the supraorbital neurovascular bundle may be within a notch or less frequently within a complete foramen. The orbitozygomatic osteotomies are designed to detach the orbit and zygomatic arch and block. Mastering these bone cuts requires practice and deliberate repetition. The most confusion comes around step 4, which is a cut that has an intracranial component and connects the inferior orbital fissure to the superior orbital fissure. The goal of this picture is for you to have a good reference in your mind of the relation between the cranial sutures and the underlying structures. Note the relation between the coronal suture and the motor strip, the squamosal suture and the sylvian fissure, or the orbit and the frontosphenoid suture. The cavernous sinus is a dense landscape of surgical trails. Knowing how to navigate it requires love to the anatomy, solid dissection skills, and good preoperative planning. Here I have removed the anterior clinate process and exposed the cavernous sinus and middle fossa. You and I could spend hours enjoying the details of this dissection and its surgical implications. The key landmarks are the proximal and distal dural rings that define the clinoidal segment of the carotid, the opticocarotid and oculomotor carotid triangles within the purple triangle, the Parkinson or infratrochlear triangle in red, the anteromedial triangle in green, which leads you to the sphenoid sinus, and the Kawase quadrangle, which is limited by the superior petrosal sinus, the trigeminal nerve, the GSPN, and the internal acoustic meatus. I will leave the rest of these trails to your indulgence. The cavernous sinus is also a turbulent confluence of venous flow. Here you have its main tributaries. The key to the cavernous sinus is understanding the main confluence point at the sphenopatroclival venous gulf, at the depths of the Parkinson's triangle around Dorello's canal, here illustrated with a star. The main outputs are the superior and inferior petrosal sinuses, the basal vein of Rosenthal, and the communication to the pterygoid sinus through the sphenoid emissary vein at the foramen of Vesalius. The endoscopic and the nasal approaches use the nasal space to access the anterior, pituitary, and posterior fossa. The medial aspect of the orbits and middle fossa can be accessed with certain limitations. This is the fascinating architecture of the nose. The key surgical landmarks are the vomer leading to the sphenoid rostrum, the cribriform plate, and the turbinates. In green is the choana, which leads to the nasopharynx, and, to our interest, it provides a straight trajectory to the clivus and the atlanto-occipital space. A close-up view of the sphenoid rostrum exposes the ostium. Notice the relation between the superior turbinate and the ostium. This is a useful surgical landmark when the mucosa is edematous. Now we are looking through the choana at the end of the left nasal corridor, beyond the nasopharynx. You can appreciate the surgical trajectory to the clivus, the occipital condyle, and the jugular foramen laterally. The sphenoid bone is arguably the most beautiful bone in the skull. It is the soul of the skull base as it shapes the orbital conus through the greater wing. It sets the transition between the anterior and middle fossa to the sphenoid ridge. It forms the anterior wall of the posterior fossa through the dorsum sellae and divides the infratemporal fossa from the nasopharynx through the pterygoid plates. This bone well deserves your love and attention. When it comes to the endoscopic endonasal approaches, it is critical to understand the relation between the roof of the choana and the pterygoid canal to expose the Vidian nerve and the pterygopalatine fossa. A bit lateral to the pterygoid canal is the foramen rotundum. Note that on top of the foramen rotundum is a superior orbital fissure, and these two are divided by the small bridge of bone known as the maxillary strut. Now take a look to the sphenoid sinus and see the septa within it. See how they curve out laterally. They most likely intersect with the carotid, so be careful to study that relation before surgery on a CTA. We will now take a quick tour through the surgical anatomy of the endoscopic endonasal approach, and I will start by entering the right nostril. First, orient yourself and take the septum as your compass. Make sure you don't tilt your endoscope during the approach, as it can lead to misjudgment of the spaces, so keep the septum vertical in the image. Now look at the inferior and middle turbinates and how they divide this space into inferior, middle, and superior meatas. I have pulled the middle turbinate medially to see the uncinate process and the bulla ethmoidalis behind it. Between the two is the hiatus semilunaris. Dividing the uncinate process will help you anticipate the orbit in the superior half and the maxillary sinus in the inferior half. Now I have stripped off the mucosa of the lateral wall of the nasal cavity, and you can see many critical landmarks. The most important are the relationship between the root of the inferior turbinate with the maxillary sinus, the tail of the middle turbinate with the sphenopalatine artery, and the tail of the superior turbinate to the sphenoid ostium. Notice the relationship between the bulla and the anterior ethmoidal artery. Here I have exposed the nasopharynx by taking down the septum, the ethmoid cells, and the rostrum of the sphenoid. On the right hand side, I have taken the posterior wall of the maxillary sinus to expose the pterygopalatine fossa. You can see V2 where the arrow points, and the Vidian nerve just medial to it. Notice the trajectory of the Vidian nerve through the pterygoid canal on its way back to the internal carotid artery. This is a golden landmark during the transclival approaches because it allows early identification of the lacerum and cavernous segments of the internal carotid artery. I invite you to understand the endoscopic endonasal approaches to the skull base as a modular concept. Each of these approaches has its own boundaries, landmarks, and targets. I hope this image helps you guide your learning of the sagittal and coronal expanded endonasal approaches. There is extensive literature on each module labeled in this picture. It is worth your time learning this, I promise. The endonasal approach offers a unique medial exposure of the cavernous sinus and the pituitary gland. Note the position of the abducens nerve between the ophthalmic nerve and the carotid artery. Don't be fooled by the sympathetic plexus around the carotid when identifying the true path of the abducens nerve, which runs posterior to the carotid. The main goal of this picture is to illustrate the superior hypophyseal arteries branching off from the medial aspect of the carotid and reaching the optic nerves and chiasm as well as the pituitary gland. They are at risk during the suprasellar approach. Notice the slope of the pituitary stalk and the position of the pituitary gland in relation with the chiasm and the carotids. Below the transsellar approach, we can access the clivus. Here I have drilled out the clivus and exposed the right hypoglossal canal. The key to be safe during the transclival approach is to understand the trajectory of the abducens nerve and the hypoglossal nerve, because these are the most ventral and reliable structures. To identify the abducens nerve, you can project a football goal with the posts at the axis of the paraclavial carotids and the horizontal bar at the foramina lacerum, where the carotid turns from the lacerum segment to the cavernous segment. The abducens nerve will be wrapped into dura, scoring a goal at each corner of our football goal by the carotid as illustrated here. A midline dural incision, therefore, will be the safest option in most of the times. This is the final cisternal exposure of the transclavial approach and its coronal expansion, the far medial approach. You are essentially looking at the same anatomy of the far lateral approach, but from the other side of the neurovascular curtain, formed by the structures passing through the internal acoustic meatus, the jugular foramen, and the hypoglossal canal. Please pause the video, take your time to appreciate each detail of this photograph, and then see, in your mind's eye, how this area would look like from the far lateral and retrosigmoid approach. Then try to build your surgical rationale and guide yourself through the golden rules of our skull-base ancestors. Do not cross the nerves and maximize bone removal to minimize neurovascular damage.